Welcome to the Black Belt Nurse Podcast, where we discuss all things related to violence in healthcare. I'm Bill Schuler, your host, and this is the place where we learn together, mull things over, and generally figure things out. Whether you're a seasoned expert, a student, or just passionate about safety in healthcare, this is the podcast for you. Before we dive in, a quick disclaimer. We do discuss all aspects of violence in healthcare, some of which may be inappropriate for younger listeners and viewers. Please use discretion. The Black Belt Nurse Podcast is for informational and educational purposes only. While we discuss experiences, strategies, and science, this podcast does not provide medical, legal, or professional advice. Always consult your healthcare institution's policies and guidelines or seek professional advice when necessary. And of course, all opinions expressed here are my own and do not represent any employer or organization. Now, let's get started. Today, we're diving into a topic that has been generating a lot of conversation in hospital settings across North America: behavioral flagging programs. You may have heard them called violence risk flags, patient alert systems, or safety alerts in your electronic health record. Whatever your organization calls them, the core idea is the same. When a patient or individual has a documented history of violent or threatening behavior, a flag or alert is placed on their record or in their record to warn healthcare workers before the encounter. Now, I know some of you have strong feelings about this. Some of you have been saved by a flag. Some of you work in places where the system is broken, and some of you might be questioning whether these flags actually work or whether they create more problems than they solve. Here's my promise to you today. We're going to look at the real evidence, 5 studies, and we're going to be honest about what they found, the good, the complicated, and the areas that still need work. Because I believe the goal of flagging isn't to label patients or stigmatize people. It's to make sure you walk into a room with your eyes open so you can come home safe. Let's get into it. Before we talk about the research, let me give a quick foundation for anyone who's new to this concept. A behavioral flagging or violent risk communication program is a formal, documented system within a healthcare organization that identifies individuals who have previously engaged in violent, threatening, or other high-risk behaviors towards healthcare workers. The purpose is to alert staff before they enter a patient's room or respond to a call so they can take appropriate precautions, adjust their approach, bring additional support, request security, or implement de-escalation strategies. In 2017, the Public Services Health and Safety Association out of Ontario, Canada, published a comprehensive handbook on exactly this topic. It's a goldmine for any organization thinking about building or improving a flagging program. They make a crucial point right off the bat. Flagging is not about punishment. It's not about denying care. It's about proactive risk communication. The same way a yellow wet floor sign is communication, not a judgment on the person who spilled the water. The handbook also walks through the legal landscape, specifically how Canadian legislation balances occupational health and safety obligations on one hand with personal health information privacy on the other. This tension, worker safety versus patient privacy, is actually central to every study we're going to talk about today. Our first study comes from Canada's largest psychiatric hospital. Researchers embedded violence risk flags directly into the electronic health record and tracked what happened over a 13-month period. They analyzed 502 violence incident reports. Here's the headline finding. When a flag was placed after a violent incident, patients who were flagged had significantly higher odds of future violent incidents, an odds ratio of 6.21. Now, before you read that the wrong way, this doesn't mean flagging caused more violence. It means that the patients who received flags were already high-risk individuals. The flag was accurately identifying the people most likely to be violent. What's encouraging is that 61% of flag patients showed fewer incidents in the post-flag period. That's real impact. That's workers being better prepared, de-escalation happening earlier, and environments being adjusted. The study also raised honest concerns. Only 20% of incident reports resulted in a flag being placed. There were gaps in the criteria for flagging. There were worries about stigmatization, particularly for patients with mental illness or substance use disorders. And there was variation in how consistently the flags were applied. This is exactly the kind of rigorous self-evaluation a program needs. Flags can work, but they need consistent criteria, clear processes, and thoughtful implementation. The next study is from Ferron and colleagues from 2022, looking at flagging practices and challenges in hospitals. This study surveyed 131 participants across 5 Ontario hospitals, nurses, allied health professionals, and managers to understand how flagging was actually being done in practice. And what they found was both validating and sobering. 3 main challenges emerged across every hospital. First, patient stigmatization. Staff were worried that flags, once placed, might never come off, or that they would cause patients to receive different or lesser care. Second, the tension between patient privacy and worker safety. Third, and this one is huge, significant gaps in policies and procedures. In other words, many hospitals had some form of flagging, but the rules around who gets flagged, why, how long the flag stays on, how it gets reviewed, those were unclear or inconsistent. What the study tells us is that the intention to flag is there. The need to flag is there. But the infrastructure to do it well is still developing in many places. For those of you in leadership positions, this is your call to action. Don't just have a flag system. Have a good one. The third study is from Mausz and colleagues from 2024 addressing flagging in emergency medical services. This study is a game changer for our EMS colleagues. Researchers looked at a paramedic service in Ontario and analyzed 502 electronic violence incident reports over time. Again, they found that flagging locations, which are addresses associated with prior violent incidents, those were linked to a significantly higher risk of future violence, with that same odds ratio of 6.21 coming through loud and clear. Now, here's something important this study highlighted. Location matters enormously in EMS. Unlike a hospital room, paramedics often respond to someone's home, a street corner, a business, places that can't always be flagged in the same way a patient record can. The study found that many violent incidents occurred at locations that weren't flaggable, which points to a real system gap. But the flags that were in place, they worked. They served as a meaningful signal that allowed teams to prepare differently. The challenge is extending that protection to the full range of environments EMS workers operate in. This is frontier work, and it's important. The fourth study is from Weerahandi and colleagues from 2025, addressing clinical perspectives at 20 academic hospitals. This one is the most recent study we're looking at, and it's the most expansive in terms of scope. It surveyed clinicians at 20 academic hospitals across the United States through the Home Run Research Network. And I want to be straight with you. This study presents some of the most challenging findings for advocates of flagging. 67% of clinicians said they didn't believe alerts prevented workplace violence. 88% reported that demographic factors influenced who got flagged, meaning there were concerns about racial and other biases creeping into the flagging process. 50% said alerts caused changes in how care was delivered to flag patients. And 21% reported witnessing adverse patient outcomes they believed were connected with a flag being in place. And 21% reported witnessing adverse patient outcomes they believed were connected to a flag being in place. These are numbers we can't ignore, and I'm not going to, because here's what I believe. The problem isn't flagging. The problem is flagging done poorly. Flagging without clear criteria, without bias training, without review processes, without accountability, that's not a safety tool. That's a liability. What this study is really calling for is standardization, training, transparency, and ongoing evaluation. It's asking us to do better, and I think we can. So what's the takeaway from 5 studies spanning hospitals, paramedic services, psychiatric settings, and academic medical centers across 2 countries? Here's how I see it. Flagging, when done well, is one of the most practical, low-cost, high-impact tools we have for communicating violence risk to frontline workers. The evidence is clear that flags identify truly high-risk individuals, people significantly more likely to be violent again. In the best cases, flagging led to better preparation, earlier de-escalation, and fewer incidents. But the evidence is equally clear that implementation is everything. Inconsistent criteria, biased application, insufficient training, lack of review processes, and poor integration into the clinical workflow can undermine the effectiveness of any flagging program and cause real harm to patients in the process. What the research is calling us toward is not abandonment of flagging, except for one study that actually does call for the abandonment of flagging. The research is calling for excellence in flagging. Thoughtful, well-governed, evidence-based flagging. Before I wrap up, I want to give you a teaser on the next podcast episode. If you're thinking about implementing, improving, or advocating for a flagging program in your organization, here are the top 10 things you need to think about first. Number 1, define clear, objective, behavior-based criteria for flag placement, not diagnosis-based, behavior-based. Flags should be triggered by documented violent or threatening behavior, not by a diagnosis of mental illness, substance use, or any other demographic characteristic. Number 2, establish a formal review and removal process. Flags should not be permanent by default. Build in regular review cycles. A flag placed 5 years ago for an incident that occurred during a psychiatric crisis may not reflect current risk. Number 3, develop a multidisciplinary flagging committee. Flag placement and removal decisions should not rest with one person. A committee including clinical, safety, privacy, and patient advocacy perspectives reduces bias and increases consistency. Number 4, train all staff on the purpose, process, and limitations of the flagging system. Flags are a communication tool, not a punishment, not a diagnosis, not a guarantee. Everyone who uses the system should understand what a flag means and what it doesn't mean. Number 5, address bias proactively. Given findings that demographic factors influence flag placement, build explicit bias awareness into your training and auditing processes. Regularly review your flagged population for demographic disparities. Number 6, integrate the flag into clinical workflow. Don't make it a parallel system. If staff have to go looking for a flag, it may not be seen in time. Flags need to appear naturally within the normal point-of-care workflow, including in the EHR, dispatch systems, and handoff communications. Number 7, ensure legal and privacy compliance from day one. Consult your legal team and privacy officer. In most jurisdictions, there is a legal basis for disclosing health information to protect worker safety, but the process must be documented and defensible. Number 8, create a transparent communication process with patients. Where appropriate and safe, consider how patients are informed that a flag exists in their record and what that means for their care. Transparency can reduce adversarial dynamics. 9, collect data and evaluate outcomes continuously. Track incidents before and after flagging. Monitor whether flagged patients experience changes in care. Measure staff confidence. Use data to improve. And number 10, pair flagging with comprehensive violence prevention infrastructure. Flags are one layer of a multi-layered safety program. They work best when paired with de-escalation training, environmental design, security partnerships, and a strong reporting culture. All right, that's a lot to take in. Here's what I want to leave you with today. The research says flagging works, and it says we can do it better. Those two things are not in conflict. They're a roadmap. The path from where we are to where we need to be runs right through better criteria, better training, better governance, and a genuine commitment to fairness. You deserve to walk into every patient encounter with the information you need to stay safe. Your patients deserve to receive care from providers who are prepared, not anxious, and in the dark. A well-designed flagging program serves both of those goals. If this episode gave you something to think about, share it with your colleagues. And if you want to dig deeper into any of these studies, I've got full citations in the show notes. That's a wrap for this episode of the Black Belt Nurse Podcast. If you enjoyed this episode, don't forget to like, subscribe, and hit that notification bell so you never miss a new episode. Drop a comment below and let me know your biggest takeaway. I would love to hear from you. You can find me on LinkedIn and Facebook, as well as blackbeltnurse.com. For now, be safe, and I'll see you in the next episode.